Welcome. The topic of discussion today is chemotherapy of tuberculosis. As you all know, tuberculosis is primarily a disease of the lungs, and it is mainly caused by a bacteria which is called as Mycobacterium tuberculosis. This Mycobacterium tuberculosis, it causes an infection primarily in the lungs, but other parts of the body are also not spared with this disease. Apart from the lungs, it may cause disease in various other parts of the body, like the brain, where it causes tuberculoma of the brain, or a TB meningitis, or it may cause TB lymphadenitis, or TB of the spine, which is called as Pott's paraplegia, resulting in a psoas abscess and paraparesis. Apart from that, tuberculosis may also seen in the intestines, that is TB, tuberculosis of the intestine. So this tuberculosis, it is not only pertaining to the lungs, but it occurs in various parts of the body. Apart from that, if you look at tuberculosis, in earlier days, it was said to prevail in people who belong to the low socio-economic groups and people who reside in overcrowded places or the slum dwellers and so on and so forth. But as of now, if you look at the scenario of tuberculosis, it is not only restricted to the overcrowded or low socio-economic strata, but this tuberculosis is also seen in people who are rich. It is also seen in countries which are developing as well as developed countries. The only reason behind that is due to HIV and AIDS. So in HIV and AIDS, tuberculosis happens to be the first infection or the very common infection associated with HIV and AIDS. Henceforth, if at all somebody comes across a patient who hails from a high class or a rich person, or so we need to test if it's positive for tuberculosis, we need to test for HIV and AIDS. Now, as I already told you, the tuberculosis, it is caused by a microorganism, that is a bacteria, the bacillus, that is Mycobacterium tuberculosis, which happens to be a chronic granulomatous disease. Rather than affecting the lungs, as I told you, it affects the other parts of the body. And when we talk about the spread of these tuberculosis or the transmission of tuberculosis, it is mainly through the droplet infection. And this droplet infection may be through coughing, sneezing, or the respiratory fluids. Now, if you look at the burden of tuberculosis in India, so as you know that India is the highest burden of tuberculosis, and 40% of the population are infected with tuberculosis at a given point of time. And the annual risk of infection is about 1.5%, whereas there's a lifetime risk of around 10%, where the incidence happens to be 21 lakhs of global incidence of 90 lakhs patients. And when we talk about the prevalence of tuberculosis, it is around 26 lakh patients. Then when you know regarding the sputum positive cases per year, the sputum positivity cases in a year is around 8 lakhs. So around 8 lakhs people in India are turning up to be sputum positive. And the death due to tuberculosis is around 0.37 million. This is the data which is taken from the Global Tuberculosis Control through the World Health Organization, Geneva. The data is derived from 2014, the year 2014. And as you know, that India is contributing to 1/5 of the global pattern or global disease pattern in the, India is contributing around 1/5 to the globe with tuberculosis, followed by China, which is around 14%, India is 21%, Indonesia is around 8%, Nigeria is 5%, followed by South Africa, Bangladesh, Ethiopia, Pakistan, and so on and so forth. So this is actually the burden of tuberculosis in India. Then, when you talk about the pharmacotherapy or the treatment modalities of tuberculosis, it is very important, where the classification mainly, the drugs are classified into first line drugs and second line drugs. When you talk regarding the first line drugs, there are 5 major drugs which are available, like Isoniazid, Rifampicin, Pyrazinamide, Ethambutol, and Streptomycin. They account to the primary first line drugs. Then when we talk about the second line drugs in the treatment of tuberculosis, we do have ethionamide, cycloserine, terizidone, para-amino salicylic acid, rifabutin, rifapentin. Then we do have another group of drugs which are called as fluoroquinolones. In the fluoroquinolones, we have moxifloxacin, levofloxacin, ufloxacin, ciprofloxacin, and amikacin. Then we do have the injectable preparations available for the treatment of tuberculosis as second line drugs. They are capreomycin, amikacin, and kanamycin. And of course, we do have newer drugs also which have come into the market to treat multi-drug resistant tuberculosis, that is bedaquiline and pritomanid. Bedaquiline and pritomanid are the newer drugs which are used for the treatment of drug-resistant tuberculosis or multi-drug resistant tuberculosis. And as you know, when a drug comes into the market, we always do a passive surveillance that is called as pharmacovigilance. But with bedaquiline, which India has taken up this drug along with the Ministry of Health and Family Welfare, and in the presence of the in the guidance of pharmacovigilance program of India, in India it has identified various designated centers of pharmacovigilance or the TB hospitals or chest hospitals where the drug bedaquiline is being tested as an active surveillance to look into the various areas associated with bedaquiline. So bedaquiline is a drug, a newer drug, which is tried across India in certain centers where we are doing active surveillance with bedaquiline. Then these anti-tuberculosis drugs are again categorized or grouped in various groups like group 1 to group 5. So these group 1 to group 5, it has been categorized, where in group 1 we have first line oral agents. This first line oral agents are your isoniazid, pyrazinamide, ethambutol, and rifampicin. Then the second group, it is classically present with injectable agents like streptomycin, kanamycin, amikacin, and capreomycin. The group 3 drugs, anti-tuberculosis drugs, are fluoroquinolones like the levofloxacin, moxifloxacin, and ufloxacin. Then when you talk about the group 4, we have oral bacteriostatic second line agents. That is oral bacteriostatic second line agents like para-amino salicylic acid, cycloserine, terizidone, ethionamide, and prothionamide. So these drugs, they are called as oral bacteriostatic second line agents, which are grouped under group 4. Then when we talk about the group 5, these agents are categorized in group 5 as the agents which do not have a clear role in the treatment of drug-resistant tuberculosis. So actually their role is unclear in the treatment of drug-resistant tuberculosis, and the drugs in these category are clofazimine, linezolid, clofazimine, linezolid, amoxicillin and clavulanic acid in the combination, thiacetazone, imipenem along with silastin. And the last drug which is available in this category is clarithromycin. So this linezolid, as you all know, it is a macrolide or macrolide. It is included in macrolide group of antibiotics. Okay, so and apart from that, we have clarithromycin. Again, it is a macrolide group of antibiotic. So these are categorized in group 5, the agents with unclear role in the treatment of drug-resistant tuberculosis. Now, we will discuss in detail regarding the first-line drugs in the tuberculosis. So we have a drug which is called as isoniazid. So isoniazid, it is designated by the letter H because this H, R, E, Z, and S, HRZES, these are the denominators which are given to the individual drug when we talk about their, what you call like the regimens, when you talk about the regimens, the various regimens, okay, in the treatment of different types of tuberculosis. So isoniazid is H. So it is mainly active only against Mycobacterium tuberculosis. This is the cheapest drug available among all the other drugs which are used for the treatment of tuberculosis. And it inhibits, basically this particular drug has two actions. One, which is having a bacteriostatic action, as well as it has bactericidal action. So when it is said to be bacteriostatic, it inhibits the resting microbes, or it inhibits the resting Mycobacterium tubercle bacilli. When I say that it is having a bactericidal action, means it acts by killing the multiplying Mycobacterium tubercle bacilli. So it does have both bacteriostatic as well as bactericidal action. And it is very effective against extracellular and intracellular organisms. Then, when we look at the mechanism of action of isoniazid, as you know, this particular drug, it is also called as isonicotinic acid hydroside. And it is mainly a prodrug which gets activated by mycobacterial catalase peroxidase. So this prodrug is converted to an active form by an enzyme which is called as mycobacterial catalase peroxidase, and this is going to act upon the it goes and forms the covalent complex with acyl carrier protein, which later on blocks the mycolic acid synthesis and kills the bacteria. So once again, I repeat the mechanism of action. Isoniazid, it is a prodrug which gets activated by Mycobacterium catalase peroxidase enzyme, that is CATG, to a covalent complex with acyl carrier protein, which then blocks the mycolic acid synthesis and kills the bacteria. Apart from that, when I talk about the resistance of isoniazid, the primary resistance is mainly due to inherent resistance. And the second type of resistance with isoniazid is there is a development of mutation of catalase peroxidase gene. The third type of resistance is mutation of INHA gene. So these are the three types of development of resistance with isonicotinic acid hydroside. So when we look into the pharmacokinetics of isoniazid, it is rapidly and completely absorbed, and it is widely distributed across the body, and it penetrates and accumulates into the caseous lesion, especially in the lung, and it has a minimum tuberculostatic concentration, that is 25 to 30 nanograms per ml. And then when you look into the metabolism of isoniazid, it is metabolized through a process which is called as N-acetylation. So N-acetylation is a type of phase reaction where it gets metabolized through N-acetylation. So here there are two types of acetylators available. So there are two subsets of population wherein isonicotinic acid hydroside may act as a slow acetylator or it may act as a rapid acetylator. So when I talk about slow acetylators, the plasma half-life is 3 hours. And when the plasma half-life is 3 hours, it may cause a drug toxicity, and which results in development of peripheral neuropathy. Okay, in slow acetylators, the T half or plasma half-life is 3 hours, causing drug toxicity, resulting in development of peripheral neuropathy as the major adverse drug reaction. Apart from that, when I look into a rapid acetylator, the plasma half-life is 1 hour, and the metabolite which is produced by this rapid acetylator causes serious toxicity, resulting in hepatotoxicity. Then, when you look into the ADR profile, adverse drug reaction profile with INH, primarily it causes peripheral neuropathy. And this peripheral neuropathy is mainly due to INH being a structural analog to pyridoxine, and it can form hydrazone, which is highly water soluble with pyridoxal, and it is rapidly excreted in the urine. So that means to say, this INH is a structural analog to pyridoxine, which gets excreted through the urine, resulting in deficiency of pyridoxine. So how do you combat this particular ADR? So here we can give a pyridoxine as prophylaxis and pyridoxine as a treatment modality in treating the toxicity. For example, when I talk about prophylaxis of pyridoxine to combat peripheral neuropathy, I can give pyridoxine 10 milligrams per day as prophylaxis. When I want to treat the toxicity due to drug, it is 100 milligrams per day. So prophylaxis is 10 milligrams. For treatment or for toxicity, it is 100 milligrams per day pyridoxine. And you very well know that in our country, India, pyridoxine is available by the trade name B long tablet B long. Now, the second type of ADR we commonly see with INH is hepatitis. So hepatitis, it mainly occurs in the elderly people as well as people with quiescent or the liver disease. And this hepatitis may be caused mainly due to the involvement of a microsomal enzyme, because INH involves the microsomal enzyme CYP2E1, which causes hepatotoxicity. And you have to remember one thing, that the first line drugs for the treatment of tuberculosis, the drugs which cause hepatitis, you have to remember there are 3 drugs primarily causing hepatitis. Number 1, INH or isonicotinic acid hydroside. Number 2 is Rifampicin, and number 3 is Pyrazinamide. So these 3 drugs may result in development of hepatotoxicity: INH, Rifampicin, and Pyrazinamide. Next, when we look into the drug interactions, as you all know, INH is an enzyme inhibitor. It is a microsomal enzyme inhibitor. So this INH reduces the metabolism of phenytoin, carbamazepine, diazepam, theophylline, and warfarin by inhibiting CYP2C19 and CYP3A4. So the one thing what you have to remember, INH is an enzyme inhibitor, so that it is going to reduce the metabolism of various drugs. So when it reduces the metabolism of phenytoin, carbamazepine, diazepam, and theophylline, warfarin, it causes increased accumulation of the drug in the body, resulting in its toxicity. Okay, then, so all this will result in development of toxic effects. For example, if I give INH along with warfarin, so the warfarin concentration in the body increases, and there will be a resultant excessive bleeding tendency. like that. Apart from that, when I talk about the other drug interactions, aluminum hydroxide inhibits the absorption of INH. So the aluminum hydroxide containing antacid. So one should not take INH along with antacid preparations so that the INH absorption will get impaired, or it inhibits the absorption of INH. Then when we talk regarding the preparations of INH, it is in the form of tablet, syrup, and injection. Tablets, they are 100 and 300 milligrams. Syrup, 50 to 100 milligrams per 5 ml. And injection, it is 100 milligrams per ml. Apart from that, the next drug which is available is rifampicin. So one should know regarding rifampicin is, rifampicin, it is a dye-based compound, and it is a semi-synthetic derivative of rifamycin B, which is obtained from Streptomycin mediterraneae. So this particular drug, rifampicin, which is a semi-synthetic derivative of rifamycin B, is obtained from Streptomycin mediterraneae. And this particular drug, it is a highly active drug, or it is a most active drug, and it is highly active against gram-positive and gram-negative cocci, enteric bacteria, mycobacteria, might be tuberculosis or leprae, and chlamydial infections. So it is highly active against gram-positive, gram-negative cocci, and enteric bacteria, Mycobacterium tuberculosis, and Mycobacterium leprae, and chlamydial infections. It is mainly effective against extracellular and intracellular organisms, and it is having a main role to play in slow dividing microorganisms. And the other property of rifampicin being, it is a sterilizing agent, and it can prevent the resistance to develop. So it can prevent the resistance with the drug. Now, what is the mechanism of action of rifampicin? Rifampicin binds to the subunit of bacterial DNA-dependent RNA polymerase, and it inhibits the RNA synthesis. So it binds to the subunit of bacterial DNA-dependent RNA polymerase, and it inhibits the RNA synthesis. Apart from that, the resistance to rifampicin is due to formation of mutations to beta subunit of bacterial RNA polymerase. Then, apart from that, if you look at the pharmacokinetics of rifampicin, it is available both as oral and intravenous formulations, but generally we do give oral preparations in the form of capsule. So this drug, it is well absorbed, but the food impairs the absorption of rifampicin. That is the reason why rifampicin is always given on an empty stomach, especially in the morning. Then this drug, it is very widely distributed in the body, and it is highly plasma protein bound. The plasma protein binding being around 80 to 90%. Coming to the plasma half-life, it has a plasma half-life of 3 hours, and the therapeutic concentration persists for more than 12 hours. And it is metabolized in the liver to an active metabolite, that is des-acetyl rifampicin, and which undergoes extensive enterohepatic circulation. So it is metabolized in the liver to an active metabolite, des-acetyl rifampicin, which undergoes enterohepatic circulation. Hence, there is a high concentration of the drug available both in the bile and in the saliva. Then, this rifampicin is excreted around 60% through the feces, and small amounts of rifampicin is excreted through the kidneys. So, dose adjustments are required in patients who are having renal impairment or renal failure. Now, what is the adverse drug reaction profile with rifampicin? As I already told you that rifampicin is a dye-based drug. So as it is a dye-based drug, when it is getting eliminated through the kidneys, it causes discoloration of the urine. So there is a red or orange discoloration of the body's fluids, especially the urine, tears, and sputum. And this it may also result in development of fatal hepatitis. So when I talk about the reddish or orange discoloration of the body fluids, especially the urine, tears, and sputum, it becomes very much mandatory when you are prescribing rifampicin to patients. One has to advise the patient regarding the discoloration of urine, because the patients may get panicked if we don't inform them that after taking rifampicin, the urine content or urine will turn to reddish or orange in color. The patient will become very much panicked. So if one informs them in beforehand or before the use of rifampicin, it is well and good, so that the patient will not panic. And this is not a very serious ADR. Because of the dye, it will present as reddish or orange colored urine. Now, when I talk about the next adverse drug reaction, it results in development of hepatitis. As I already told you, isonicotinic acid hydrozide, rifampicin, and pyrazinamide, three drugs which are the first line drugs in the treatment of tuberculosis, may result in development of fatal hepatitis or hepatotoxicity. The third ADR is flu-like syndrome, and the very common ones are nausea, vomiting, and sometimes it may result in development of dizziness and confusion. Apart from that, when we talk regarding the drug interactions with rifampicin, as I already discussed regarding INH, INH is an enzyme inhibitor, microsomal enzyme inhibitor. Rifampicin is a powerful microsomal enzyme inducer. That means to say, this rifampicin, it is going to induce its own metabolism, and it can induce the metabolism of other drugs like phenytoin sodium, oral contraceptive pills, glucocorticoids, clarithromycin, ketoconazole, and theophylline. So when this particular drug is going to induce the metabolism of other drugs, the concentration of these drugs in the body reduced. Hence, there is a drug failure. For example, if somebody or if a lady takes oral contraceptive pills and she is taking rifampicin without the knowledge that the doctor does not know that the lady is taking oral contraceptive pills to prevent pregnancy, and she takes rifampicin, there's a contraceptive failure, because there's increased metabolism of oral contraceptive pills, and there's a drug failure resulting in the pregnancy state. So this is how the effect of other drugs is getting reduced, and there is a drug failure, because rifampicin being a powerful microsomal enzyme inducer. Then, when you talk regarding the uses, or what are the therapeutic uses of rifampicin, rifampicin, as I told you, it is used primarily in the treatment of tuberculosis. It is also used in the treatment of atypical mycobacterial infections like Mycobacterium avium, Mycobacterium bovis, Mycobacterium consortii, Mycobacterium scrofulaceae, and so on and so forth. So these atypical mycobacterial infections, they are very commonly seen in patients with HIV and AIDS, and also in patients with immune compromise. And the other therapeutic uses are, it is used in the treatment of leprosy. So here we do use rifampicin in the treatment of leprosy, that is once monthly dosing. Apart from that, rifampicin is also used in the prophylaxis of Haemophilus influenzae. Number 4, it is used in the treatment of resistant Staphylococcus aureus infections. Number 5, it is also used in the treatment of brucellosis. Number 6, it is used in the treatment of pneumococcal meningitis, and most of the times it is used to eradicate the carrier states. Then, what are the preparations of rifampicin? Rifampicin is available in the oral preparations in the form of capsules. We have 150, 300, 450, and 600 milligrams of rifampicin capsules. So how do you determine the dose of rifampicin with the body weight, with respect to body weight? Suppose if the individual is less than 50 kilograms, we do give 450 milligrams of rifampicin, and if the individual is more than 50 kilograms, we do give 600 milligrams of rifampicin. And rifampicin is also available in the form of syrup used for the treatment in children. Now, We have a third category of drug in the first line management, that is pyrazinamide, that is Z. Pyrazinamide is Z. This pyrazinamide, it is a synthetic and orally effective bactericidal drug. So this is a bactericidal drug, synthetic preparation, very well effective orally. And this is used along with INH and rifampicin. Pyrazinamide, it is a prodrug which gets converted to pyrazinoic acid. And this pyrazinoic acid is being converted from pyrazinamide by pyrazine aminidase of Mycobacterium tuberculosis. And it is an inactive at neutral pH, and it is actually a bactericidal to dividing microorganisms. So it acts as a bactericidal drug when the microorganisms are dividing, and it is an intracellular bactericidal drug. It is also a sterilizing agent like your rifampicin. Then, when you talk regarding the mechanism of action of pyrazinamide, the mechanism of action is not definite, but we can say that there is a gene which is called as PNCA gene enzyme, which activates the pyrazinamide to an active compound, which is pyrazinoic acid, which then interacts with a different fatty acid synthase encoding gene that causes inhibition of the synthesis of mycolic acids, which reduce the content of lipids in the mycobacteria, causing the damage to the mycobacteria. So this is not a definite mechanism, but it has been said that this gene, which activates pyrazinamide to pyrazinoic acid, which then interacts with a different fatty acid synthase encoding gene and causes inhibition of the synthesis of mycolic acids, whereby reducing the lipid content in the mycobacteria. Then, when you talk regarding the resistance of pyrazinamide, the resistance is mainly due to a mutation, development of mutations with respect to PNCA gene. And the second type of resistance is impairment or impaired uptake of the pyrazinamide drug into the cell, bacterial cell. Then, the pharmacokinetics. So as you all know, it is widely distributed across the body, and it is also concentrated in the cerebrospinal fluid. Hence, it becomes the mainstay in treating the tuberculous meningitis. So pyrazinamide becomes the mainstay of treating tuberculous meningitis because it is also concentrated in the cerebrospinal fluid. This drug, it is very safe in pregnancy, and it is metabolized in the liver and excreted in the urine. When I talk about the plasma half-life, it is 6 to 10 hours, and the dosage is extending from 25 to 35 milligrams per kg per day. Then, coming to adverse drug reaction profile, hepatotoxicity is a major adverse drug reaction, and hence this pyrazinamide, it is contraindicated in liver disease. Then the second adverse drug reaction is hyperuricemia. So apart from hepatotoxicity, it also causes hyperuricemia, and it may precipitate gout and gouty arthritis. The third most important adverse drug reaction is arthralgia. So remember, pyrazinamide causing hepatotoxicity, hyperuricemia, arthralgia, and associated to that, it may also have fever, malaise, urticaria, skin rashes, and the common one is GI upset like anorexia, nausea, and vomiting. Next, coming to the preparations of pyrazinamide. So there is availability of pyrazinamide in the form of tablets, that is 500, 750, and 1000 milligrams tablets are available of pyrazinamide. And the dose is around 25 milligrams per kg per day. And the dose should not exceed 1.5 grams per day. And in children, the dose is 15 to 30 milligrams per kg per day. Then coming to the last but one drug in this category, that is ethambutol. This ethambutol is designated by the letter E. It is a tuberculostatic drug, and which acts on fast multiplying organisms. It is effective on fast multiplying organisms, and it is also effective against atypical mycobacteria, and it is taken up by the erythrocytes and later it is slowly released into the circulation. It can also hasten the sputum conversion and prevent the development of resistance. So in this ethambutol, resistance emerges rapidly if the drug is used alone. Per se, no drug is used alone in the treatment of tuberculosis because it may emerge development of resistance. So that is the reason why there are certain diseases like tuberculosis, leprosy, HIV, AIDS, and cancer where we do give multi-drug therapy, especially leprosy, HIV, and tuberculosis. We use multi-drug therapy to prevent emergence of resistance when we use a single drug. Then it is also used as an alternative to streptomycin, because if the person is not comfortable with the ethambutol resulting in toxicity like optic neuritis, we do give streptomycin, and the person is not comfortable with streptomycin, it can be converted to ethambutol like that. So it is used as an alternative to streptomycin. Then what is the mechanism of action of ethambutol? So this ethambutol, it mainly inhibits mycobacterial arabinosyl transferase involved in polymerization reaction of arabinoglycan, which is essential component of mycobacterial cell wall. So I repeat, the mechanism of action of ethambutol is it acts by inhibiting the mycobacterial arabinosyl transferase enzyme, which is involved in polymerization reaction of arabinoglycan, which is essential component of mycobacterial cell wall. And the mechanism of resistance of ethambutol is development of mutation of EMB gene. Then coming to the pharmacokinetics, 75 to 80% of the drug is absorbed from the gastrointestinal tract, and it is very well distributed. And this particular drug also crosses the blood-brain barrier, but in situations where the meninges are inflamed. So whenever there is an inflammation of the meninges, the drug gets, or it crosses the blood-brain barrier and reaches the brain. So that is the reason why this particular drug ethambutol is also may be indicated in the treatment of tuberculous meningitis. Apart from that, this particular drug is excreted or eliminated by glomerular filtration and tubular secretion. So it is excreted or eliminated by glomerular filtration and tubercular secretion. When you talk regarding the plasma half-life, it is 4 hours, and dosage is 15 to 13 milligrams per kg per day. When you talk regarding the adverse drug reaction profile, as I told you, ethambutol starts with the letter E and I letter E. Please remember ethambutol and I. What is the side effect or ADR? It is optic neuritis. So that is how you can remember the adverse drug reaction with ethambutol. So ethambutol causes adverse drug reaction in the eye. What is that ADR? That is optic neuritis. And this optic neuritis is also dose dependent and dose related. So initially, the person will develop red or green color blindness followed by a decrease in the visual acuity. And this particular complication or side effect may disappear following withdrawal of the drug. Apart from optic neuritis as a ADR, the next ADR is hypersensitivity reaction, which may result in development of a skin rash, fever, or itching. And the other side effects are arthralgia, gastrointestinal disturbance, headache, and mental disturbance. Now coming to the last drug in this category, that is the first line drugs, is your streptomycin. And this streptomycin was the first drug clinically useful first drug clinically useful for the treatment of tuberculosis. This particular drug is obtained from Streptomyces griseus. It is obtained from Streptomyces griseus, which is the first clinically useful drug in the treatment of tuberculosis. And this particular drug is very well active, mainly against extracellular bacilli. and it is a supplemental first-line drug which can be supplemented to ethambutol. Then when you look into the dosage of streptomycin, it is 1 gram per day or 15 milligrams per kg per day, given either intramuscular or intravenous. But generally we do give intramuscular injection, especially intragluteal injection. Then when you look into the mechanism of action of streptomycin, it acts by interfering with the initiation complex of peptide formation. Hence, the initiation complex of peptide formation, when it interferes with that, it results in misreading of mRNA with an incorporation of an incorrect amino acid sequence into the peptide, resulting in a formation of a non-functional or a toxic protein, which leads to the breakup of polysomes into the non-functional monosomes, resulting in damage of the mycobacteria. So the mechanism of action is it acts by interfering with the initiation complex of a peptide formation, resulting in misreading of mRNA, which causes incorporation of incorrect amino acid sequences into the peptide chains, leading to a non-functional or non-toxic protein which is formed, leading to breakup of polysomes into the non-functional monosomes, and hence there is a damage to the mycobacteria. Then what is the mechanism of resistance to streptomycin? The first mechanism of resistance is production of an enzyme transferase which inactivates the aminoglycoside by acetylation, adenylation, or phosphorylation, which is a major action. So by acetylation, adenylation, or phosphorylation of aminoglycoside. Why aminoglycoside? Because streptomycin belongs to aminoglycoside group of antibiotics. This is the major action developing or resulting in development of resistance to streptomycin. The second mode of resistance is impaired entry of drug into the cell. And the third mode of resistance is there's a development of receptor protein on 30S ribosomal subunit, which is deleted or altered with the formation of mutation. So receptor protein on 30S ribosomal subunit is deleted or altered by formation of mutation. So three mechanisms of development of resistance is seen with streptomycin. Now, coming to the adverse drug reaction profile, again the adverse drug reaction profile is very well similar to other aminoglycoside antibiotics, and this particular ADR is again dose related or dose dependent, and there is a very much increase in the risk of these ADRs in elderly people. The ADRs, the main ADRs are adverse drug reactions are ototoxicity, nephrotoxicity, development of rash and fever. So the majority or main is ototoxicity. If there is a high dose, it may also lead to development of nephrotoxicity, but the primary ADR with streptomycin happens to be ototoxicity. Now, when you summarize, when I come to the summary of the primary first line drugs, one side you have, the left side we have the drugs, the right side we have the mechanism of action. So if you look into Isoniazid, the mechanism of action is it inhibits the synthesis of mycolic acid, an essential component of bacterial cell wall. Number two, Rifampicin or Rifabutin, it binds to and inhibits the DNA-dependent RNA polymerase, and hence no new RNA synthesis occurs. Number three, Ethambutol, it inhibits the arabinosyl transferase enzyme and prevents the polymerization of arabinoglycans, which is the essential component of mycobacterial cell wall. Number four, that is Pyrazinamide, it acts by inhibiting the mycobacterial fatty acid synthase 1 enzyme and disrupts the mycolic acid synthesis. So this is in a nutshell the various mechanism of actions of the primary first line drugs used in the treatment of tuberculosis. Then this slide also depicts the same mechanism of actions. If you look into this, Isoniazid. Isoniazid, it inhibits the cell wall synthesis. Ethambutol, it inhibits the cell wall synthesis. Pyrazinamide, the exact target of its action is not known, but it is said that it disrupts the plasma membrane, disrupts the energy metabolism, that is the energy which is not formed, that is ATP, and ATP synthesis is not happening because this particular pyrazinamide, it is disrupting the energy metabolism. And apart from that, if you look at the rifampicin, it inhibits the RNA synthesis, so that the DNA coiling, transcription and translation processes, and RNA and protein synthesis, they do not occur. Hence, it will damage the mycobacteria. So if you look into when these drugs were come into the market, the first drug which has come into the market is Isoniazid. It is in 1952. The next drug, Ethambutol, is in 1961. Pyrazinamide, again, it is in 1952. That is Isoniazid and Pyrazinamide. They were launched in the year 1952, followed by Ethambutol, it is 1961, and Rifampicin, 1966. Then, this is the last slide of my discussion of today's talk. Here in this slide, I would like to show you what are the various clinical settings and what is the daily dose of various first-line drugs used in the treatment of tuberculosis. If I look into Rifampicin, the dose in children, it is 10 to 20 milligrams per kg per day. Rifampicin in adults, more than 50 kilograms, it is 60 milligrams per day. Less than 50 milligrams, it is 50 kilograms, it is 450 milligrams per day. Isoniazid in children, it is 10 milligrams per kg per day. In adults, it is 200 to 300 milligrams per day. If you look at Ethambutol, it has a specialty. In children and adults, in the initial first 8 weeks or initial 8 weeks, the dose is similar in children and adults. For Ethambutol, it is 25 milligrams per kg, whereas after 8 weeks in children and adults, it is 15 milligrams per kg. When you look into pyrazinamide, in children and adults, the dose is 20 to 35 milligrams per kg. Streptomycin in children is given as 30 milligrams per kg dose, and in adult it is 1 gram daily. So with this, I think I have come to the end of the class, and the second line drugs in the treatment of tuberculosis will follow in the next session. Thank you very much.